So good morning, and thank you for being here. Today we're going to be talking about belly pain, but before we dive into that, I just wanted to take a moment to express my gratitude. I know that as medical directors, we can be a cantankerous bunch, and it's easier for us to focus on the things that go wrong than the things that go right. So my stepmother fell off the roof last week and was transported to Peace Health as a trauma alert. And just to know as a member of the community, just to know in my bones that she was going to get great pre-hospital care, just made all the difference in the world. So I just wanted to express my gratitude for what you do every day and how well you do it. And just know that it's really appreciated both by us as medical directors, but just by us as members of the community. So with that, I'm going to go ahead and get started. Give me a minute to share my screen here. Okay, so I trust that you can see my screen now. I will keep an eye on the chat for questions. Also, feel free to raise your hand or to just jump in with questions as we go. My goal is to keep this a focused and productive presentation. And I trust that there's someone else who can let in anyone who is waiting in the lobby. So today we're going to talk about abdominal pain, and I want to talk about what makes abdominal pain unique as something we treat both in the hospital and the pre-hospital setting. So when we think about problems that originate with the central nervous system, we've got our neuro exam to guide us and to help us to figure out what's going on. When we think about problems that go on in the lungs, we've got auscultation, we've got end-tidal CO2, we've got pulse oximetry to give us a sense of what's going on. With cardiac problems, we have the EKG, and then with musculoskeletal problems, we have our exam. But then we've got this area here where it's just really hard to figure out what's going on, and particularly in the pre-hospital setting, there are relatively few tools that we have that really give us a sense of what's going on. And so it's really a question of thinking about what is going on in there, and how do we pick up the clues, and how do we put the whole picture together. And why does this matter? Well, one, it's a huge chunk of what we do. It's approximately 30% of all the calls we run involve abdominal pain. But then I think it's easy, because it's so common, to underappreciate how potentially life-threatening it is. So particularly in the elderly patients, if you are seeing someone over 65 with abdominal pain, at least half of those patients are going to wind up hospitalized. And of all the patients, there's about a 40% misdiagnosis rate. And I think it's very tempting to feel like, well, they're just going to put them in the CAT scanner and they're going to sort out what's going on. But even with CT scan, with ultrasound, and with all these tools we have, it's difficult to come up with the right diagnosis. And what we're thinking about in the differential really guides what kind of imaging study we do, whether it's ultrasound, whether it's a CT that's focused on the vessels, a CT that's focused on the intestinal contents. And so this is a real challenge for us as a team to come up with the diagnosis. And then with elderly patients with abdominal pain, about 10% of them die. So the mortality rate for an elderly person with abdominal pain is roughly the same as the mortality rate for STEMI. And so this is, I think, is deserving of our attention, but deserving of being a team that tries to put all the clues together to come up with the right diagnosis. And so my goals for today are to take the information and the experience you already have, and to fine-tune the approach to abdominal pain, and to give you a few specific things that you can key in on. I'm going to review some specific pitfalls. We'll go through a number of diagnoses, and my goal is to keep this brief and focused and to give you the few things that really matter for pre-hospital care when you're thinking about these diagnoses, when you're seeing someone who's been given one of these diagnoses. And then just to emphasize how potentially life-threatening, particularly abdominal pain in the elderly is. So first, we're going to talk about how we figure it out. And so I'm going to emphasize a few key components in the history and the physical. So we all know about our OPQRST history, but with abdominal pain, the onset gives some really important clues. And so sudden onset can be with a number of things, but with a sudden onset, we need to at least consider a vascular cause. And this can be one of the most difficult things that we do in medicine is you see someone like squirming around, writhing on the bed. And one of the things that really stuck with me is that you see someone like that, it's either really something or it's nothing. But the patients that are really uncomfortable and all of a sudden really uncomfortable, and they have that exam with pain out of proportion to the exam, that is something that is concerning for a vascular cause. And it can be easy to blow off because the exam's not that impressive. And so that getting that piece of the history and describing what they look like when you got to them is really important. Understanding what provokes and palliates them is, in terms of the pain, can be really important. Understanding the quality of the pain can give us some clues. But particularly in abdominal pain, these can be vague and it can be pretty hard to pin down. The radiation of the pain gives some important clues. And remember that in the abdomen, visceral nerves are very nonspecific. So you break your arm, you know that your arm hurts right there. But belly pain can be, it's difficult to localize based on the location that the patient feels the pain. And then the other thing is that it's confusing is that the nerve fibers follow the embryologic origin. So, a male with testicular pathology is going to feel pain along the flank because that's where the testicles originated in embryo and then descended. And so there can be, the pain doesn't follow a typical pattern that you can just say, there's the pain, so there's the problem. And then the timing of the pain can be another important clue, and that'll come up with a number of the diagnoses that we talk about. Risk factors can really help us to figure out, and then to really key in on, alcohol completely changes the differential for abdominal pain. And that's something that I think you as pre-hospital providers are particularly good at sorting out. And you get these environmental clues, like what did the house look like? When you went into the medicine cabinet, was it just filled with bottles of vodka? Those are things that you can pick up clues that we would miss in the hospital. And so having your curious eyes and your experienced eyes in there is particularly helpful. Other things to think about for vascular causes, and then also for GI bleed, smoking really contributes. And then particularly for GI bleed, NSAID use is definitely a risk factor. In the physical exam, there are a couple of important things to key in on. So this picture on the right here is the eye of a sheep. And so this is a guide for anemia that's published so you can decide when you need to deworm your sheep. Now, deworming is not in our arsenal, but transfusion is. And this guide, like pulling down someone's mucous membranes and looking at the eye, can give you a really important clue to whether they are anemic or not. And so if you look down your eyes, this is someone who's got a hemoglobin of like 5 or less. This is someone around 7 who's got the, probably need a transfusion. This is someone who could be having symptoms from their anemia. And then these are people who likely are not anemic. But as you think about GI bleed, this can be an important clue. serial vital signs are a really important clue. And so for, to say that like the vital signs are normal is not nearly as helpful as just describing exactly what they were, because when we're hearing the report from you, we're starting to, I don't know if someone has their microphone on, I'm starting to get some feedback. If you're not speaking, that would be helpful.
Somebody needs.
Okay, so I've gone ahead and muted everyone. Sorry for that interruption. So the serial vital signs are really important. So when I'm hearing the report, I am starting this process of trending vital signs and trying to figure out which way things are going. So having the precise numbers is particularly important, and especially as with trauma, a single episode of hypotension is a really important predictor of badness. And so that's something that's important to know. Skin signs, and those are things that really can change, especially in response to your treatment. And so describing what the skin looked like, especially before treatment for pain, or what happened when they stood up to get to the gurney, that's really helpful. Obviously, your palpation is important. And I find it's helpful to describe what you find on palpation is, first where the tenderness is, and then was it mild, like they winced a little bit? Was it moderate, meaning like you could obviously see that they were in discomfort when you press, or is it severe, like they have significant pain with any mild palpation? That is also part of this, some of the stuff we trend. How does the abdominal exam change over time? And then something that takes time and clinical experience to pick up is understanding what the surgical abdomen feels like. But this is that rigid belly that's just severely tender. And in almost every single case, that's someone who's going to need relatively urgent surgical intervention. And so just, to describe, they have rebound, they are guarding, they have a rigid abdomen. That in the HERE report is really helpful to hear. I think that tympany, tapping on the belly, is definitely something that is within your scope and can give you some important clues. Because if you're thinking, man, this person might have a bowel obstruction, and you tap on their belly and it sounds like a drum, like that is a very different situation than like you tap on the belly and it just sounds like it's full of fluid. It's dull, it's dull to your percussion, like someone with ascites that just has a belly full of fluid. Because the most life-threatening causes of abdominal pain are vascular causes, your pulse exam is particularly important. And that is a case where you can pick up someone who, pulse deficit for an aortic aneurysm is one of the chief warning signs. And so if you're thinking about that, as much as you can, expose the feet, expose the legs, check the pulses, check your pulses in the upper extremities. That can be really helpful, because finding, you take the boot off and you find a cold blue leg, that's really going to change the way you approach the case. And then just understanding the entrances and exits. So looking at someone's mouth and seeing that it's really dry. And then obviously your ability to examine the groin is more limited in the pre-hospital setting. But we'll talk about a couple instances where just taking a quick peek so there are no major surprises there can really clue you in to what's going on. So with that, I'm going to move on to some specific diagnoses. Before we do that, any questions about history and physical? Okay. So hearing nothing, we'll move on. And the way that I'm going to structure this is that we'll talk about specific groups of problems. So first, we're going to talk about vascular problems, which, as I mentioned, tend to present with a sudden and severe pain. So the king of all of these is the acute aortic syndrome. And these can be very difficult to pick up. These diagnoses are talked about as the great masquerader because they can present with so many other symptoms. One of the biggest clues that you're dealing with aortic pathology is that you've got pain in the trunk, whether it's chest pain or abdominal pain or both, plus something else. So chest pain and a neurologic symptom suggests a thoracic dissection. Chest pain and arm pain is something to be concerned about. Belly pain and leg pain. But it can also be belly pain and blood in the urine, or belly pain and feeling lightheaded. This is something that can present as a syncopal episode. Know that the aorta is retroperitoneal, and the importance of that is that anything like the pancreas, the aorta that's retroperitoneal is harder to pick up on your belly exam. And so just having this in your mind and thinking about the possibility of aortic pathology can help you pick up some important clues. One of the clues is if someone has a AAA that's being watched, and even if someone has a AAA that has been repaired, that's something that can have problems in on down the line. The most feared complication of that is that you can have an aortoenteric fistula where the graft essentially wears away into the intestines. And so then at some point it breaks, and then essentially you've got the contents of the aorta coming out into the intestinal tract. And so you can have massive bright red blood per rectum. Mesenteric ischemia is another vascular cause of sudden severe abdominal pain. And so this can present in a couple of different ways. People can have just generally poor circulation and can have pain that gets worse with eating. And you can think of it as similar to cardiac chest pain that gets worse with exertion, or if you have peripheral arterial disease and you have pain in your legs that gets worse with walking. There's just poor vascular supply, and that when the demand is placed on it, they have pain. But you can also have an acute plaque that breaks off, or a clot. And so people who are vasculopaths are at risk for this. People with clot-forming conditions like atrial fibrillation are at risk for this. And again, these are patients who tend to have this severe pain that's out of proportion to exam. You can also have dead gut, just in the setting of a bowel obstruction, where the guts gets twisted, the vascular supply gets cut off, and those tend to be people who have some pretty severe pain. Those people tend to have pain tend to have a pretty concerning exam. So now we're going to move on to things that affect the digestive system. And in general, these are things that are much more gradual in onset, with a few exceptions. So GI bleed tends to be relatively gradual in onset. The esophageal varices that are ruptured are probably the biggest exception to that. And so this is a case where the things you pick up on scene can give us important clues to what's going on. So when we're seeing the vomiting of bright red blood, that can give us a clue. Obviously, the coffee ground emesis can give us a clue. Typically, patients that have melena have an upper GI bleed because the blood has had the time to transit the intestine, get mixed with stool, and turn black. Whereas bright red blood per rectum is typically lower abdominal pain, lower GI tract bleeding. And so we mentioned the risk factors. Obviously, anticoagulants as well may put you at risk for bad outcome with respect to GI bleeding. And then obviously, these are the cases where, in addition to the belly pain and the hemodynamic instability, you may need to think about managing the airway. And these can be some of the more challenging airways that we face. So pancreatitis, when you're a medical student starting on a surgical rotation, One of the things they tell you is listen to what the attending says and stay the F away from the pancreas. Because the pancreas is filled with these powerful digestive enzymes that essentially digest meat, digest everything. And so if the enzymes from the pancreas spill out into the abdomen, you can get quite sick. And this tends to be really severe pain, generally gradual in onset. Pancreas is retroperitoneal, and so the pain often radiates to the back. The vast majority of cases are related to alcohol, and so picking that up in the history can be very helpful. Another 25% are related to gallstones, and then there's about 5% that are from drugs and other causes that can be tougher to figure out. Patients with pancreatitis sometimes can be discharged if they're doing fairly well, but they can progress, and because of the powerful inflammation that you can get if you're spilling pancreatic enzymes, you can get into multi-system organ failure, patients that essentially present like they're in severe sepsis because of the significant inflammation related to the pancreas. We mentioned gallstones can lead to pancreatic problems, and then gallstones can obviously lead to acute cholecystitis as well. So the liver makes bile, the gallbladder stores the bile, and then the stones can form in there. And then the bile then drains after getting input from the pancreas as well, and so it drains into the duodenum. The bile is what gives the stool its brown color. Without that, it's clay colored. And so typically with acute cholecystitis, there's a gallstone stuck in the neck of the gallbladder. The gallbladder gets inflamed, and then these patients can get quite sick. Generally, taking the gallbladder out in acute cholecystitis is not a next hour thing, but generally, next 24 hours thing. And then obviously we can see patients who have pain from stones without having acute cholecystitis, and they can often have their pain managed and then have their gallbladder taken out at a later time. But picking up a fever is something that can clue us into acute cholecystitis. So chronic liver disease typically doesn't present with significant pain, and I think the more important thing is to think about how this affects everything else. So when you see the stigmata of chronic liver disease, obviously you can see the big belly with ascites. You could feel a hard liver. You can see the caput medusae, these dilated veins because of the portal hypertension, because as the blood goes through, the cirrhotic liver just has trouble making it through there. Men can develop gynecomastia because they can't break down estrogens. You get scleral icterus, and then these other signs. Probably one of the most important things to clue on is that you can get asterixis when you get hepatic encephalopathy. And so that's this liver flap where you ask them to hold their hands up, and there's this kind of semi-rhythmic flap. It's not like the tremor that you get with alcohol abuse, but more of a flap. In patients that are really attended, you can just hold their hand up and it'll just flap against you. And then there's this characteristic breath that you get in patients that have liver failure. Obviously, all of these signs that we pick up with breath are harder in the world where everyone is masked. So acute liver failure can be from hepatitis, or it can be from other causes, most commonly Tylenol ingestion. But the other liver toxins that we deal with are hallucinogenic mushrooms. And so these patients get jaundice, they have the clay-colored stools, the scleral icterus, and this tends to come on relatively rapidly. Going back to the hollow organs, so bowel obstruction is something that we deal with relatively frequently, and there are a lot of important clinical clues for this. So these patients tend to vomit, and they have decreased or no stool output. The biggest risk factor for this is a history of prior surgeries, and the more invasive the surgery, the greater the risk. So a patient who's had a laparoscopic surgery has some risk, but relatively low. Patients who had major XLAP for trauma, they have a much higher risk for having bowel obstruction. And these patients the breath can just smell like feces. They tend to have this really distended abdomen that sounds like a drum. And then perforated viscous, essentially the intestine at some place ruptures. That's the surgical abdomen that I was talking about earlier. And so what this X-ray shows is free air under the diaphragm. Obviously not a pre-hospital diagnosis, but so normally you see the liver right up against the diaphragm here, but the fact that you're seeing air under here and then air between the stomach and the diaphragm is that's what lets you make this diagnosis on a chest X-ray. But the key thing in the pre-hospital exam is they have this peritoneal exam. They have this rigid belly, and generally they were having pain for some time that all of a sudden got much worse. And these are patients, once you see this on an X-ray, this is a patient that needs to go to the operating room. Another thing that we deal with commonly is diverticulitis. So this is pain that is most commonly in the left lower quadrant, although it can be anywhere in the abdomen, that typically comes on fairly gradually. And so what happens is you have these diverticuli, these pockets that form off the colon. Interestingly, in people who eat a diet that has zero processed food, they don't develop these, but most patients who eat a Western diet by age 40 or 50 start to develop some diverticuli. And so these diverticuli, they can start to get inflamed, whether it's a piece of stool or a nut or something in here, they get inflamed. And if it's just inflammation around here, then that's simple diverticulitis. We can manage their pain and they can take oral intake, then they can be treated as an outpatient. Where this becomes more concerning is that if it then develops, and of these patients that we send home, 95% do well, but about 5% will go on to develop complicated diverticulitis. And so the diverticuli will get more and more dilated, and then you get this purulent, feculent material, and then you can get little rupture. And so you can have perforation, and where you essentially got stool contents free in the abdomen, or you can get a walled off abscess that forms. And those patients typically present with fever, and they're not responding to the antibiotics. Though it's something important to know that in someone who is sent home with diverticulitis, they definitely have the potential to get worse. Obviously, appendicitis is something we think about really commonly. The goal with appendicitis is to make the diagnosis in the first 72 hours of symptoms, because that's when you really get into the risk of rupture. And I think that the place this comes up in pre-hospital care is when you're contemplating someone who is feeling better, not feeling that terrible, and they're wanting to refuse. Especially with a kid, the situation is really different if you're on day 1 of symptoms versus if you're on day 3 or 4 of symptoms. And so a kid with 3 or 4 days of belly pain, we really need to make the diagnosis, because then they're at risk for rupture. A simple appendicitis treated with surgery has a pretty good course. A ruptured appendicitis tend to have a much rocky course. Simple appendicitis is typically a day in the hospital. A ruptured appendicitis is typically a week in the hospital. Serial exams can be necessary, so it's not uncommon, especially if we're seeing a kid early on in their course, to examine them. Things aren't that concerning. We send them home, but with a plan to re-examine them. And so it's important to know that if they were there, they had an ultrasound, and then a day later they're having worsening pain. That doesn't mean it's not appendicitis, and those are patients we really like to see again. And then it's important to know with appendicitis that the symptoms can be pretty vague, especially in preverbal kids. And then, especially in the elderly, it tends to be harder for them to localize their pain. And so appendicitis can present in with a very non-specific presentation in the elderly. We do see a lot of patients that have inflammatory bowel disease. And this often gets confused with irritable bowel syndrome. Irritable bowel syndrome is annoying but generally benign. Inflammatory bowel disease, meaning Crohn's disease, ulcerative colitis. These can be tricky patients because they often deal with belly pain, but they are also at much higher risk for complications. So Crohn's disease tends to skip around and affect different parts of both the small intestine and the large intestine. Ulcerative colitis tends to affect the last portions of the large intestine and around the rectum. So these patients are at risk for getting bowel obstructions. They're at risk for developing abscesses. And then they are often on immunosuppressive medications, which puts them at high risk for getting sick from other things. Cannabinoid hyperemesis syndrome is not life-threatening, but it's something that we're seeing more and more, particularly with the legalization of marijuana. So these are patients who are typically daily marijuana users for at least a year, and they develop this, really intractable vomiting. It comes episodically. It tends to be relieved, like their symptoms go away when they have hot showers. And so that's an important clue, but it's important to remember this is a diagnosis of exclusion. And so just because someone is a daily marijuana user doesn't mean that there can't be something more dangerous going on. And then the last thing with respect to the digestive system is that I think in the pre-hospital setting, there are a lot of opportunities to pick up clues about foreign bodies. And this can be in infants and toddlers, and psychiatric patients, and it can be, this is one place where a little bit of history can give the whole case away. This could be a topic for a whole other lecture, but just a reminder, the things to worry about are especially ingesting true magnets. We're now seeing more of these rare earth magnets that really stick strongly, and one of them will typically pass through the gut without difficulty. But if you have two of them, then they can become stuck together on opposite sides and then erode through the intestinal wall, and those patients can get quite sick. Obviously, button batteries in the upper esophagus can make kids quite sick, and then sharp objects, obviously, we worry about. With that, I'll take a quick pause to see if there are any questions about digestive system, and then we'll move on to genitourinary problems. Okay, so we'll go ahead and move on. So I will, I'm going to lump together both the urinary system and then the genital system, because these tend to present similarly, and we typically can't think about one without thinking about the other. So one of the most common of these is renal colic. I think by this point we all recognize that typical presentation with renal colic is patients that just can't get comfortable or having a severe flank pain. Probably the most important thing to know about renal colic is that AAA can be misdiagnosed as renal colic because it's also a sudden onset severe pain. If it's affecting the renal arteries, the patients can have hematuria as well. And so it's important to keep an open mind if you're seeing someone who looks like they have renal colic. Acute pyelonephritis is an infection of the upper urinary tract. So it typically starts with a lower urinary tract infection, but then presents to flank pain, fever. These patients often vomit a lot. And so these patients can have severe sepsis. And it's important when we think about renal colic to think about pyelonephritis as well, because pyelonephritis is something that you can just treat with antibiotics. Patients that have renal colic and infection tend to get quite sick, and they need a surgical procedure to relieve the obstruction that's associated with the stone. As we're talking about urinary tract infections, I'm just going to take a brief minute to talk about how things have changed with how we think about urinary tract infections. And so there's been a significant shift over the last 5 years. We are trying to be much more selective in who we give antibiotics to. And so I think when I started in practice, it was very common. You had someone who felt vaguely unwell or didn't even feel too bad, and then you see either white cells in the urine or bacteria in the urine. You're like, oh, well, they must have a UTI. And you'll hear patients say like, oh, they told me I had a UTI, but I didn't have any symptoms. And so what we see is that these patients, if they don't have any symptoms, you can't make them feel any better with antibiotics. In elderly women, roughly 10, if you just sample 10%, sample their urine, even patients who are having no symptoms, about 10% have bacteria in the urine without symptoms. You can also have bacteria in the urine without symptoms in men. And it's also very common in patients who are catheterized. They can be colonized and have bacteria, but not really have an infection and not have anything that causes problems. And so it's important to note, like, foul smell doesn't mean that you have a urinary tract infection. Cloudy or dark urine doesn't mean that you have a urinary tract infection. And that in an elderly patient with confusion, we have to be very careful about attributing their symptoms to a urinary tract infection. And so to make the, we've all been in that situation where you see someone and they smell like urine, and it smells bad, it smells foul, and there's this thing that we often hear repeated, oh, it smells like a UTI. But the truth is, like, that person just smells like urine, and that doesn't necessarily mean that they have a urinary tract infection. So to diagnose a urinary tract infection, we need to have urinary symptoms, dysuria, frequency, urgency, suprapubic pain, and then a UA that fits with that. Obviously, there are gray area in patients that are demented, that are otherwise confused, but we're trying to be much more selective in who we give antibiotics to, because what we do find is that otherwise nice little old ladies who get diagnosed with these recurrent urinary tract infections without symptoms over time are becoming breeding grounds for these superbugs that are resistant to all sorts of antibiotics. And so it's an area in which we're trying to be really cautious and careful. So acute renal failure is typically painless. The reason it's important to think about that in the pre-hospital setting is that it sets you up for hyperkalemia. And so this can be someone who's missed their dialysis, or it can be just someone who's not producing urine, not taking in enough fluid, or has some underlying renal disease that just got tipped over the edge. And it can be very, very vague and a very non-specific presentation. Just say when someone is just not quite right and you're thinking about it, the 12 lead is important, and thinking about hyperkalemia, especially if you're seeing odd arrhythmias, is important. One of the most life-threatening GU diagnoses is Fournier's gangrene. So this is necrotizing fasciitis of the groin. It's almost always in someone who is immunosuppressed or immunocompromised. The single biggest risk factor is diabetes, but any kind of immunosuppression can set you up for that. And this is when I mentioned that, if you can find an opportunity in the pre-hospital care to just take a peek, this is one of those times where that quick look can absolutely change the course of the case. Because if you see this discoloration in the groin. It can be in men or women, but you see this discoloration. They tend to have severe pain, often out of proportion to exam. They can have crepitance when you press in that area, because these are flesh-eating, gas-forming bacteria. And then this, the infection tends to go much deeper than this, and they need an urgent trip to the operating room. Testicular torsion is another time-sensitive emergency. This can occur in neonates, and then the second most common group are boys just after puberty. It's pretty rare, but not unheard of after that, and tends to be very rare after 40. So it's typically a sudden onset severe pain. And the clues that you pick up on exam are that that testicle is typically higher than the other one. It doesn't have the cremasteric reflex, meaning when you touch the thigh, it does not lift up. And it can be discolored on the outside, but it's more that it has this abnormal lie. And another thing just to think about, especially in someone with a sudden onset testicular pain, and you can see it's often different to pick up because neonates aren't great at giving history, and boys that have just had puberty are terrible about giving history about this. But this is a surgical emergency. Time is testicle, and typically gets twisted around to the inside. So in the emergency department, as ER docs, we can try to reduce the torsion. We talk about opening the book, and so we twist to the outside, and sometimes can get patient relief with that, but they still need a trip to the operating room. It does help to know that if someone's gone to the operating room with testicular torsion, the urologist will typically put a stitch down on both testicles. So it's very rare to have torsion in someone who's already had a surgery for torsion. Obviously, the ovaries can torse as well. Ovarian torsion, we typically need to have a cyst that makes the ovaries, you can think of kind of like a sail, and makes it more likely to twist. It's also a sudden onset and severe pain. It can be an intermittent pain like testicular torsion can, because it can torse and untorse. And also, it's also time sensitive. And in general, with about 6 hours of a torsed testicle or ovary, you'll lose that reproductive organ. So with the women that are risk factors for this are women with a history of ovarian cysts or polycystic ovarian syndrome. And then there is, with a cyst by itself, you can get hemodynamically unstable. You have a large cyst that ruptures, you can have significant bleeding. Obviously, in any woman of reproductive age, we think about ectopic pregnancy as well. And so it's always a consideration. And there are obviously a lot of misconceptions that people will feel like, oh no, I can't be pregnant because of whatever contraceptive method they used, or because they just they just had a period. So it's always something that we think about. One of the important things in the pre-hospital setting is that these patients can be quite hemodynamically unstable if they rupture. But the unique thing about this presentation is that they're hypotensive, but they're also bradycardic. No one exactly knows why, but when you fill the belly with blood from an ectopic pregnancy, it is common to get bradycardia. It's important to know that a lot of women you can be treated as an outpatient with an ectopic pregnancy. So if you have a relatively small ectopic pregnancy, you can get medicines like methotrexate that will treat the ectopic pregnancy. And so for the most part, they go home, they do well, but they are at risk for rupture. And so that's another important thing that, the clue that you can pick up. So I'm going to move on to wrap up with my take-home points. So Abdominal pain is really common and the diagnosis is difficult. It's tempting to feel like, well, there's really not much we can do for this in the pre-hospital setting, but I would ask you to see yourself as part of the team, because we absolutely see you as part of the team that is trying to pick up the clues, trying to make the diagnosis. And so every little piece of the history, every little piece of the clinical course that you can pick up in your time with the patient is helpful to the patient and ultimately making the diagnosis. We absolutely want your teamwork in taking care of these patients. And so with that, I will take any questions that you guys have. Okay, I'm not hearing any questions. Feel free to follow up later if anything else comes up. My last ask is I would really welcome any feedback that you can give, because we want to continue to make PCEP as the best learning experience possible. I will also post this link in the chat so you can click on that. And again, so I really thank you for your attention. You can also follow this QR code to give feedback. And we absolutely want to continue to make better and better learning with PCEP. So again, thank you for what you do and have a great day.
Thanks, Marlo.
Marlo, did you send a